All right, well, I appreciate that I was granted an extended didactic time than we usually have, which is much appreciated for this particular didactic on violence risk assessment in routine clinical settings, because it's quite a big topic to bite off. You cannot do justice to this topic if you speak only about the assessment process. We also have to make mention of documentation and management practices. So we'll really just skim the surface with this brief. It's going to be about 30-minute didactic. But at the end of this didactic, I'm going to be sharing with you some resources that you can all check out for more information and to really extend your learning, including an e-learning course that will be coming out that I and some colleagues of mine at Yale and here at University of Washington are getting online in the next 2 weeks. So our time together will be spent trying to achieve the following objectives. I'll first orient you to a framework, a stage-wise framework for conducting a violence risk assessment. We will identify empirically based risk and protective factors associated with violence, identify strategies for gathering data relevant to a clinical violence risk assessment, and then I mentioned provide resources for additional learning. You'll hear me throughout this presentation use the term clinical violence risk assessment, and that's really intended to differentiate it from a forensic violence risk assessment. We know that nobody on this call is trained as a forensic practitioner, and it's a high bar to meet to do a violence risk assessment using structured professional judgment and actuarial measures. So this is really a framework for how you would do this in a clinical setting. And why is that important? Well, it's important because we know that risk assessment and risk management have become central elements, not just in forensic practice, but in all of mental health practice. And this is increasingly apparent as, since the 1960s, we've seen more and more folks treated on an outpatient basis, despite having some really emergent and pressing clinical needs and oftentimes some issues with behavioral control. And yet we as the clinicians are really charged with maintaining their safety and the public safety. And there really are no national professional standards about how a clinician would conduct a violence risk assessment. Legal standards vary by state. In terms of the mental health professional's obligations to the public and to the individual. There are very, very few systematic workforce development efforts, which is something that we're trying to address at the Northwest MHTTC and is being addressed by a couple of universities also throughout the country. But again, nothing really widespread or systematic in terms of how do we better equip our clinicians to assess and manage the risk of violence in a clinical setting. So I want to start by really defining some terms. And so we'll talk about what is risk assessment, but I want to first ensure that we're clear on what it is not. So risk assessment is not risk prediction. We as mere mortals tend to be pretty bad at fortune telling, and we're particularly bad at fortune telling uncommon or low base rate behaviors. And by and large, violence is a low base rate behavior. And later in this presentation, I'll share, first of all, what is a base rate, and second of all, what are our violence base rates. But this is something that is not that common. So let's talk about what risk assessment is. It is the integration of multiple data sources into an empirically informed clinical decision about risk for future violence. And these clinical decisions are informed by looking at past behavior, current circumstances, and future plans to identify what is the likelihood that a person will engage in an act of violence. And the focus in our risk assessments is really to identify and study the hazards. What are the things that increase the likelihood for aggressing against others in order to reduce the probability of their occurrence? And so we'll spend a fair amount of our time together in this brief didactic discussing risk factors that are important for looking at risk, but also to mitigate risk. In kind of that same vein of defining our terms, not all violence is the same. So there are subtypes of violence, and this could be broken down even more than the 3 broad categories I have here. But generally speaking, we have an affective or impulsive type violence. These are situational acts. They occur in response to a perceived threat or a provocation. It's not premeditated. We have instrumental violence, which are premeditated acts of aggression that's useful in obtaining some secondary goal. And that could be a physical good, or it could be maintaining esteem and ego. And then we have psychotic type aggression, which is violent behavior that occurs in the context of active psychosis for a psychotic reason. So we'll touch a little bit on each of these, and I'll try to be specific if there's something that pertains to only one of these subtypes of violence, but know again that we're going to be pretty high level here, so we won't get too nuanced. Best practice in clinical violence risk assessment requires that we are using as many data sources as possible. So I'll give you some guidance as to, aside from that clinical interview, what else should you be looking at, or who else should you be conferring with? We will be synthesizing our findings, and for those of you on our Washington State PACT teams, you are already getting practice at these synthesized findings through the exercises that you engage in with a comprehensive assessment, really kind of taking all these data points and saying, all right, how does this fit together? And we'll be doing that a little bit with the client Chuck that we'll be talking about today as well. Recognizing the limitations, so we don't, again, we're not predicting what this person will engage in or not engage in the future, or we recognize that we were limited in the number of data sources that we had or the quality of those data sources. We want to be mindful of integrating appraisal into the treatment plan. That is really why we're doing this, is to have some meaningful impact on this person's well-being, recovery, and their ability to stay safe and out of institutions. We will want our violence risk assessments to be culturally informed. And when I say culturally informed, that means both that we're accounting for the other person's reference groups and how that factors in to risk and protective factors, but also that we're aware of our own biases, implicit or otherwise, and how that might be factoring into our formulation of risk. And then finally, accounting for known trauma history. Now, we don't always have good data sources. We don't always have good, our clients may not be good historians, but when we know or have reason to believe that there's a trauma history, we definitely want to account for that, both because it increases their risk, and we'll talk about that as one of our risk factors, but also because it factors into how we approach their care. Okay, so pertaining to our first learning objective, which is really identifying key stages as a framework for engaging in this process. Stage 1 is to identify, or in the case of an existing client where we know we have known risk factors, revisiting the potential for risk. So if you have a client that has some static risk factors or has some kind of things in their history that raise concern, then this is something that needs to be done dynamically. We need to constantly be revisiting this potential for risk. Is there a new threat that the client made or that others perceive? Was there a recent destabilizer in their environment or in terms of their psychiatric symptoms? Did they recently aggress? Is there another kind of change that we are aware of? And in that case, we want to do a new risk assessment. Stage 2 is to conduct a systematic and comprehensive assessment of risk that incorporates relevant base rates and known or available risk and protective factors. And so that's what we'll spend the bulk of our didactic talking about. Stage 3, documentation, and really categorizing their risk status. So we can't ever come up with, a kind of percent likelihood of how likely they are to engage in a future act of violence, but we can stratify their risk based on low, moderate, or high categories. And then stage 4, take preventative action, alter the care plan. These are our management, our sort of acute management, and then sort of longer term treatment approaches. And then stage 5, evaluate the success of your actions. So this is where team-based care really complements this process nicely, because there are a lot of eyes on this. There are a lot of people who are involved. You're staffing this client regularly, so you can say, this is what we did. How effective was it? What else do we need to be thinking about? So we talked about the subtypes of violence. Let's talk about the risk and protective factors that are at play. And in particular, you want to be thinking about static, stable, dynamic, and future risk factors, and then protective factors. So not just risk and protective, but specifically within risk. What are those factors that we can't change, that are fixed and historical? What are factors that are long-term and likely to endure, but are malleable? What are dynamic risk factors where they might fluctuate over time? And what are some anticipated risk factors that might be coming down the line in the next couple of weeks or so? And then, of course, our protective factors. So that's what we're going to move into in just a minute. But the other piece of this is base rates. So many scholars in the area of violence risk assessment consider base rates, which are the known rate of violence among a particular group of people, to be the single most important piece of information for making an accurate assessment of risk. It's not the only piece, not by a long shot, but it is a good foundation for to start from. So a couple of important base rates. One is gender, the other is age. In terms of our FBI statistics, we do see a difference in base rates of violence between males and females. Now, remember at the beginning I said violence is a low base rate behavior. So these are statistics from the FBI as of 2012. 0.05 of women in the United States and 0.2% of men in the United States engaged in an act of violence. So that's kind of, I don't know, maybe shocking to some. It was to me. And then when we look at a sample of individuals who had undergone an inpatient psychiatric stay within the past year, the rates of violence were actually roughly equal between men and women, and they were higher than we see in the general population. Now, I think it's really important to call out that the definition of violence and the way that they ascertained whether a violent act had occurred in the Robbins study was different than in the FBI calculation. So that's why you see such pronounced differences between those base rates. But it was also more sensitive to the kinds of acts of violence that don't typically get picked up in arrests, which are interpersonal violence within the family. And so that's why we do see that women actually do participate in that kind of violence more than outside of the home. And so that's why we see that those rates are roughly comparable between men and women who were recently discharged from a psych inpatient stay. And then a general rule of thumb for age is that the more advanced the age, the lower the base rate. So about the base rate for violence among adolescents was 25 to 30%. So you can see that that's a very critical time point and high risk time. So jumping into our static risk factors, past perpetration of violence is one of the strongest predictors of future violence. So we're looking both for criminal history, like arrest and conviction, as well as self or collateral reports of things like bar fights, domestic violence. And what's important to note is that past violence as a predictor of future violence holds up in essentially every group that has been studied in risk research. And so this is not something where we see a lot of difference. So certainly this is something that we'll want to account for, but I will say that context or the setting really matters. So violence committed in one setting, like the individual's neighborhood, does not necessarily translate to risk in a different setting, like an inpatient setting. The other thing that's an important static risk factor to be mindful of is past victimization. And in particular, we're looking at both the seriousness and the frequency of childhood abuse. And then another critical static risk factor is their compliance with past supervision or treatment, and looking at compliance also with things like probation, lesser restrictive orders, and treatment plan. Stable risk factors. So the construct of psychopathy really refers to this enduring pattern of interpersonal, affective, and behavioral characteristics that tend to violate social norms. So lack of empathy, rule breaking, a glib or superficial charm. It's distinct from antisocial personality disorder, but there is some overlap there. And it's most reliably measured with a tool called the Psychopathy Checklist Revised, or the PCLR. Now, it's not reasonable to think that our clients will have had a PCLR in their past that we have access to, nor that there'd be anybody who could administer a PCLR, which requires a high level of training. But you can look for things that would be scored on a PCLR, like childhood history of oppositional defiance disorder or conduct disorder, a history of cruelty to animals or fire setting. So those kinds of behavioral indicators are really helpful to factor in, even if we don't know somebody's score on the psychopathy checklist. And then cluster B personality disorders, so those impulsive affective personality disorders, where you see a lot of stimulation seeking, low self-control, irritability, hostility, and potentially for some of them, like for antisocial personality disorder, antisocial attitudes, values, and beliefs. And I would say antisocial attitudes, values, beliefs, and peers, independent of whether somebody has a cluster B personality disorder, tends to be one of the 4 most robust indicators of potential for future violence. We also want to be looking at a substance use disorder. So we know that substance use is dynamic and will fluctuate. We'll talk about that in a minute. But if they have a history of a substance use disorder, that's something that we do want to capture because it does count as a stable risk factor. And then psychiatric status. So that one is a kind of tricky. We want to talk a little bit about where some of our data about whether psychiatric status increases or doesn't increase the risk of violence, and how we derive that information. So the largest and arguably the most rigorous longitudinal study of violence among individuals with mental illness was the MacArthur Violence Risk Assessment Study. And many of you may have heard of this. It started back in the 90s, and we have longitudinal data that come out still, but we have 951 inpatients between the ages of 18 to 40 across 3 major US cities. You see the breakdown of the diagnoses for these 951 individuals. And then they looked at baseline when they were still on inpatient, and then post-discharge in 10-week increments, they looked at violent acts as assessed by self-report, arrest, or collateral report. And so here's what they found. Within 20 weeks of discharge, about 1 in 5 people had committed an act of violence. By 12 months, we saw just a little bit of an increase there to about 27% had increase in violence. So already that tells us that post-discharge is a high-risk period. And I'm sure that's something you guys know. You didn't need a study to tell you. They looked at 134 different risk factors, and they found that 70 were significantly related to community violence in a way that was statistically meaningful. So when they broke out that 27% rate, what they found was that for people who had both one of those psychiatric diagnoses and a substance use disorder, that rate of violence was 31%. But those who did not have a comorbid substance use disorder, that rate was about 18%. And again, that is a statistically meaningful difference there. So substance use came out as one of the greatest risk factors for violence. And this question about whether whether there is a link between schizophrenia and violence is really a contentious issue. There was a recent meta-analysis and systematic review of a lot of literature, international literature that's come out in the last 10 years. And this actually can be accessed for free online if you're interested in reading the study yourself. But this is 18,000 individuals across 20 studies and 11 countries were included in the systematic review and meta-analysis. And they found that there was a lot of variability in risk of violence among individuals with psychosis, that overall, they did find an association compared to people without schizophrenia between violent behavior and schizophrenia, but that risk was actually mediated by substance use. So the prevalence of violence among individuals with psychosis plus substance use was similar to that of individuals with substance use and no psychosis. So that really does mean we need to be on the lookout for any kind of substance use whenever there's a concern about the person being a potential harm to others. Okay, so that's our number one dynamic risk factor, either comorbid with mental illness or not. And then additional risk factors with regard to psychiatric status would include command auditory hallucinations, particularly when the person believes that the voices have power over them, or when the individual does things to appease the voices or to comply with the voices. And then particular types of delusions, persecutory delusions, and then what are called threat control override or TCO delusions. And these are the kinds of beliefs where the person believes that not only do others mean them harm, but that their thoughts are not their own and that their mind or behavior is being manipulated by outside forces. And some research indicates that TCO delusions may double the risk of aggression. Now, an important modifier to this finding is really what is the emotional response to these experiences. Many people, in fact, I would say most people, have persecutory ideation and are quite fearful in response. And these are the folks that are staying indoors, they're not engaging with other people. But some people have an emotional response of anger, and that increases the likelihood of violence or aggression, particularly when they're engaging in these ruminative fantasies of how they're going to get revenge on the other person. So again, be thinking about our client Chuck that we're going to be talking about later as we're going through these risk factors. So looking at still at our dynamic factors, I mentioned antisocial peers, family, attitudes, beliefs. Negative affect in general is a dynamic risk factor, and in particular, anger, depression, and anxiety or agitation. I mentioned violent ruminations, poor treatment adherence and engagement right now, not just historical, employment instability, and then a violent victimization or a suicide attempt in the past week. In terms of future risk factors, we want to be looking at exposure or re-exposure to known triggers for violence. That's where that history is really important. A recent loss, and that could be to perceived status or something more physical like housing, a job, a relationship, substance, and then substance relapse if we expect that the person is at high risk for relapsing. Our protective factors for violence look extremely similar to our protective factors for suicide, so I'm not going to spend a lot of time on that, but we really want to kind of be looking at these protective factors in terms of our management and treatment. What can we do to shore these protective factors up? So we're going to shift now to learning objective 3, which really intends to provide guidance on strategies for gathering data that would be needed for a clinical violence risk assessment. In light of the kind of broad range of all of the risk factors that we just reviewed, this ACTION acronym provides a really helpful kind of mnemonic for 6 lines of inquiry that the clinician should be using to guide your appraisal of risk. And this was outlined by Drs. Randy Borum and Marissa Reddy in a 2000 paper that I'll link, or I'll share the full citation with you at the end, because it's available online in the public domain. And it was based off of an approach to risk assessment that was developed by the US Secret Service. So the first is attitudes that support or facilitate violence. We talked about that being one of the most robust risk factors. Capacity or means to carry out violence. The thresholds, have they done anything towards this plan? So thinking about the young woman who's in the news today with her plans to reenact Columbine in Denver, she clearly had engaged in preparatory behaviors. Intent to commit the act, and also imminence. So asking them what might get in the way, how might you overcome that? So really, how much have they really thought this out? How intent are they? What do other people make of their plans? Do other people think that they intend to carry it out? And then finally, non-compliance with risk reduction interventions. So have you set up some strategies already that they're just not, they're not adhering to? So the clinical interview will be a primary data point, but we also want to be thinking about, of course, looking at criminal justice system records. We want to be looking at, other treatment providers, both past and present, whenever possible. And within our clinical interview, there's a couple of recommendations that I have. One is to really adopt this Columbo style, which is, curious, open-ended questioning that really is non-judgmental and kind of maybe even there's some normalization in there. A lot of people struggle with these kinds of thoughts or fantasies. Tell me, what kinds of thoughts or fantasies have you had about hurting other people? So you're kind of assuming it in there in a non-judgmental way and using an open-ended question, not do you or don't you. You want to be tying this line of inquiry to the client's long-term goals. So, because we know it's so important for you to stay, to take care of your mom, because we know you've been working on reconnecting with your children, because we know how horrible, prison was for you and you would do anything to stay out of it, we really want to make sure that we are on top of this. Don't dance around the issue. You are not going to give somebody ideas when you're assessing for risk of violence. That theory has been discredited in multiple domains: sexual trauma, suicide, and violence. So really just be direct, tactful, but direct. And then don't really be thinking about this in terms of black or white. So it's not, is this factor absent or present, but is it possibly present? Is it present to a moderate degree? That will help you think about those risk categories of low, moderate, or high that we thought about earlier, if you're already in that mindset. And then think about incorporating symptom measures. And the ones I would recommend the most, I believe all of which are in the public domain, are the Beck Hopelessness Scale, the Novico Anger Scale, the Patient Health Questionnaire 9, and you can adapt item 9 so it's specific to homicide or violence, the Paranoia Scale, and then the Beliefs About Voices Questionnaire. Our dynamic risk factors are our most critical intervention points. So we want to be thinking about what can I do to reduce the risk posed in the short term, and those are things like means restriction, a 72-hour hold, and then what can be done to completely eliminate this risk factor. And that, of course, refers to our treatment strategies, right? So if we're thinking about this is a cluster B issue, we want to, what intervention tools do we have? Dialectical behavior therapy, impulse control strategies, stress tolerance. Documentation. So here are all the different things that we want to be mindful of in terms of our documentation, not just our risk formulation or categorization, but also what are we doing in the short term, and then that you have consulted or received supervision, because that in terms of liability, you need to be able to document that this is not just your professional opinion, this is something that another reasonable clinician would have agreed with and in fact did agree with. Or if there's a discrepancy there, you can document it and say why you're choosing to proceed with the course of action you're choosing. And then just some key terms that you can throw into your notes based on the information available to this writer, and then you'd specify that in, the formulation. And that was really kind of a CYA in terms of, listen, I know I wasn't dealing with all the data points that I could have had, but this is what I had available in the moment. Who you consulted with. If they're external to your agency, you want to seek permission before you put their name in the chart, and that they're believed to be at an elevated risk of future violence due to, and then you'd enumerate what the risk factors are, you put in the risk category, and then on the basis of elevated risk, the following measures will be taken, and you're very clearly laying out what that plan is, and you're very clearly laying out that you have gone over this with the client as well. So always update the treatment plan whenever there's a change to risk status, and make sure that you're mentioning what you're doing in terms of the short-term management, long-term treatment, and any kind of contingencies for violence. So anything that might make it more likely that the person would engage in that act of violence. Is there a way that you can manage that by connecting with a collateral, for instance, or a loved one? And then continuous monitoring and reassessment. If duty to warn or duty to protect is invoked due to a serious, imminent, or explicit threat of physical harm or death, Of course, you want to make all possible attempts to notify the prospective victim, and you take on ownership of that. We're not, kind of dispatching that to somebody else. Notifying law enforcement, an involuntary treatment or a voluntary commitment with disclosure to others. And I know we've got folks from different states on the call, so I'll just kind of remind you that there have been Tarasoff extension cases in our respective states. And so you'll want to be mindful of what are the laws that pertain to you in your state with regard to duty to warn or duty to protect. Okay, if you are interested in learning more, some freely available resources. One is, online. You can look up 2 of the articles that I mentioned. Randy Borum's article on improving clinical practice of violence risk assessment, and the other one that I mentioned based on the U.S. Secret Service risk assessment process. Online resources. So Dr. Charles Scott, who's a forensic psychiatrist at UC Davis, has a really nice and quick practical guide to evaluating psychotic patients' risk of violence. And this is both print and audio, if you click on the link on the screen. And then finally, I mentioned, I think very briefly, but the Northwest Mental Health Technology Transfer Center in about 2 weeks will be releasing a 3-hour e-learning course on confidentiality, obligation to third parties, which are duty to warn or duty to protect, and then violence risk assessment, documentation, and management. And this was a course that I put together with Dr. Kate Michelson, a forensic psychiatrist based at the Puget Sound Veterans Administration and University of Washington, as well as Tobias Wasser, a forensic psychiatrist at Yale University, and then myself. It does this topic a little bit more justice because it's a 3-hour course as opposed to a 30-minute course. So I have the link to MHTTC's website there if you would like to stay in touch with us to find out when that's released. Thank you, and I think we have a little bit of time for questions.